Hello and welcome. This is Medicosis Perfectionalis, where medicine makes perfect sense. We continue our playlist called Pulmonology. In the previous video, we have talked about lung cancer and pleural effusion. Today, I'll talk about deep venous thrombosis or DVT. This Virchow's triad, endothelial damage, blood stasis, and hypercoagulability increases your risk of arterial and or venous thromboses. With that being said, now let's get started. Hemostasis, or prevention of blood loss by forming a clot, consists of vasoconstriction, temporary plate plug, or primary hemostasis, coagulation, also known as secondary hemostasis, and then fibrinolysis to dissolve the clot and restore the function. And by the way, I have another playlist called Bleeding and Coagulation Disorders, and we have talked about this stuff for a long time. This guy, Rudolf Virchow, it's not Virchow, it's Virchow's. He's German. Respect the language. All right. Triad of endothelial damage, blood stasis, and hypercoagulability. This is what increases your risk of having clots or thrombosis. What is venous thrombosis? It's a thrombus in the vein. Oh, really? You don't say. Could be single or multiple. What's the structure of a thrombus? Red blood cells, white blood cells, platelets bound with each other with fibrin fibers, and you'll find lines of Zahn. There is a difference between a thrombus and a clot. Thrombus is usually a term we call it in vivo, or as long as you are alive. So once you're dead, your blood does not thrombose, it clots. But that's a topic for another time. It's attached to the vessel wall. This is a thrombus. But if it forms in a stupid test tube, this is not a thrombus, this is a clot. And the thrombus has lines of Zahn, and the clot does not. What the flip is the Virchow's triad? Number 1, blood stasis. 2, endothelial damage. 3, hypercoagulability. Let's talk about blood stasis, the most important factor. Prolonged immobilization. If you are sleeping on bed, let's say after a major surgery, for like 3 days, 4 days, and you're not walking enough, you are at increased risk of developing deep venous thrombosis. People, please keep moving. And as I like to say, motion equals promotion, stagnation equals escalation. Why? Bedridden patient, such as after surgery, paralysis or paresis, which means weakness, plaster cast, and the elderly. Also a long flight. An example on your exam is a trip from Australia to USA, or the opposite. This is a very long flight. If you are sitting and not moving, you are at increased risk of having DVT. Endothelial damage could be caused by hypertension, medical devices or implants, or homocystinemia. So here is the blood vessel, here are the endothelial cells, and below them is the collagen. Homocystinemia destroys the collagen, it damages the blood vessel wall, not necessarily the endothelium, but I just lump them all together. So if you want to put homocystinemia here, I'm not going to be mad at you. What is hypercoagulability? Increased coagulation could be due to increased primary hemostasis or due to increased secondary hemostasis. Primary hemostasis is the platelet plug. So if you have high platelet count, such as essential thrombocytosis, that's a more theoretical thing, because there is a difference between thrombocytosis and thrombophilia. These are not the same. Thrombocytosis means you are just having lots of platelets. Thrombophilia means you are loving thrombosis, and these are not the same. Can a patient with essential thrombocytosis develop a clot? Absolutely. But just because your platelets are high doesn't necessarily mean that you're going to get a DVT. Also, it could be due to increased secondary hemostasis. This is the blood coagulation, the coagulation pathway, intrinsic and extrinsic, as you know. Factor V Leiden is by far the most common hereditary thrombosis syndrome. Or it could be a deficiency of protein C and S, deficiency of antithrombin 3, so these are two deficiencies. When you have a patient with antithrombin 3, he or she will require more heparin for anticoagulation. Nephrotic syndrome, why? Because in nephrotic syndrome, I'm losing antithrombin 3 in the urine. When you lose it in the urine, it's called antithrombin. You will end up with thrombosis. Oral contraceptive pills, especially if a female is smoking cigarettes at the same time. As Dr. Galian said, a lady who is on oral contraceptive pills and smoking cigarettes at the same time is asking for a thrombus. I know this sounds harsh, but it's actually true. Don't smoke cigarettes, please. Pregnancy, lupus anticoagulant, which is a freaking wrong name. It's actually procoagulant. pancreatic cancer, leading to something weird called migratory thrombophlebitis, also known as thrombophlebitis migrans, also known as Trousseau sign of malignancy. We have two Trousseau signs in medicine. Number one, for malignancy, such as pancreatic cancer or gastric cancer or maybe even lung cancer. There is another one. Do you know it? Yes, in tetany, hypocalcemia. Trousseau sign is when you inflate the blood pressure cuff around the patient's arm, and then they will develop carpal spasm if they have hypocalcemia. And of course, liver cancer or any freaking cancer. Where are these venous thromboses located? The most common one is the DVT, deep venous thrombosis. Which vein? Please be specific. Number one is the deep veins of the calf. Could be anterior, posterior, or peroneal, which means fibular veins related to the fibula. Popliteal vein or femoral vein. Pelvic veins, big time. Portal vein, and I have a video called Portal Vein Thrombosis on my glorious channel. Hepatic veins such as Budd-Chiari syndrome, and it's associated with polycythemia vera, which is a myeloproliferative neoplasm, as well as paroxysmal nocturnal hemoglobinuria, which is a freaking hemolytic anemia. Brains, dural venous sinuses such as cavernous sinus thrombosis and sigmoid sinus thrombosis. I've talked about cavernous sinus thrombosis in my video called rhinosinusitis. DVT of the calf. First, the acute presentation. On your exam question, here is the typical patient. I'm giving you all of the risk factors at once. 46-year-old, G5P5, female who is on oral contraceptives, has a medical history of breast cancer and ovarian cancer that she is being treated for currently. She has also had major surgery 5 days ago and just arrived from a long flight from Sydney to New York. Presents with a right calf that's swollen, warm, red, and tender. There is pitting ankle edema on her right ankle. You also notice some collateral non-varicose superficial veins. When you tried to dorsiflex the right foot, she felt substantial pain. On compressing the right calf, she felt pain as well. The left lower extremity is perfectly fine. What's the diagnosis? This is DVT. What's the name of the sign when you dorsiflex the foot? This is Homan sign. Positive Homan sign equals DVT. Does that mean in all cases? No. What is the cause of the right ankle edema? When you have a thrombus, you prevent the drainage of the veins. The veins cannot go up. The blood starts pooling here. And when the blood starts pooling, this increases the hydrostatic pressure, leading to extravasation of fluid, which is a plasma infiltrate. And this will lead to ankle edema and swelling. Is this pitting or non-pitting? If it's a transudate, it's pitting. Be careful, superficial thrombophlebitis may coexist with deep venous thrombosis, so you get the superficial and the deep at the same time in the same patient. What's the chronic clinical picture or presentation of DVT? You might find varicose veins secondary to the obstruction. Stasis dermatitis, big time. It's usually around or above the ipsilateral medial malleolus. So here is the ankle, and here is the medial malleolus. You will see brown discoloration just above this medial malleolus, and this is called stasis dermatitis. Okay, it could be red to blue. Why blue? Because of the ischemia. Why brown like this? Because when you bleed, you have blood. Blood has RBCs. RBCs have hemoglobin. Hemoglobin has heme and globin. Heme has iron and protoporphyrin. Iron will lead to hemosiderin deposition, and hemosiderin is brown. Punctate hemorrhages and skull ulceration due to the freaking ischemia. Pathogenesis, you increase the venous pressure due to the clots. You decrease tissue oxygenation leading to ischemia. When there is ischemia, you will start to ooze and leak some blood, and this blood contains heme, which has iron, and the iron is called hemosiderin, and this is the reason why you have hemosiderosis and brown discoloration of the skin just above the ipsilateral medial malleolus. How to diagnose DVT? You need venous duplex ultrasound, very sensitive and specific, and it can even confirm the diagnosis of DVT. D-dimer. It has a diagnostic value and a prognostic value. What's the diagnostic value? It's an evidence that there is an active clot being broken down. What's the prognostic value? Can predict recurrence of DVT after discontinuation of anticoagulant therapy. What's the normal reference of the D-dimer? It's less than 500. If you find it less than 250, there is low risk of DVT recurrence. But if it's more than 250, there is increased risk of DVT recurrence after discontinuation of anticoagulation. I have a video called D-dimer. In brief, here is the clot, and you form fibrin, and then the fibrin is converted into stabilized fibrin by the fibrin stabilizing factor, also known as factor 13. Now let's dissolve the clot and restore the function. The hero here is the plasmin. It's going to destroy the fibrinogen into fibrinogen degradation products. It's going to destroy the fibrin into fibrin degradation products. It's going to destroy the stabilized fibrin into D-dimer. When you see high levels of D-dimer in the blood, it means there was a clot here and it's starting to getting dissolved. This is bad news because this clot can dislodge from the nice vein and goes up to the lung, causing pulmonary embolism. Let's say that we have a patient with DVT and no pulmonary embolism. How to manage DVT alone? Same as you manage pulmonary embolism. We'll discuss this in the next video. What's the norm historically? If it's painful, you give anticoagulant. If it's painless, you do not give anticoagulant, just observe via serial ultrasound. Now, if this is controversial and doctors argue with each other and then they start to curse and it gets ugly. To prevent DVT before it happens, historically, we used to recommend long stocking, very tight stocking like this, or socks that's very long and the patient should wear to decrease his or her risk of DVT. Today, nonsense. Why? Because they do more harm than good. They don't actually prevent DVT and they can lead to skin damage. You can give subcutaneous low molecular weight heparin or subcutaneous unfractionated heparin. Honestly, they will protect you from pulmonary embolism, but they will not protect you from DVT and they do not reduce mortality. What if the patient is at high risk of bleeding? Should I give heparin? Shut up, you do not give heparin. What do? You use intermittent pneumatic compression. This is a device containing air pump and an inflatable sleeve that you put around the patient's leg, and it improves venous circulation. It's kind of a massage using, air pump, something like, this is like physics. Wells criteria for DVT. We have Wells criteria for DVT and we have Wells criteria for PE. Big difference. Let's talk about DVT. Here is the score. When you see this in a patient, you add 1 and then you calculate. 0 score, very low probability of DVT. 1 to 2, moderate probability. 3 or more, high probability of DVT, and your antenna should go off. This is dangerous. Okay, what's the score? If the patient has active cancer, you give him 1. What do you mean by active cancer? I mean current cancer or within the past 6 months. This is considered recent. 1 for recent immobilization, let's say long flight, bedridden patient, surgery, whatever. 1 for recently bedridden or major surgery. 1 for localized tenderness on the veins. So, here is the leg. Anatomically, veins follow like a path. When you palpate this and this area is tender over the vein, this is DVT. But when it's something very far from the vein, like ankle, this is not DVT. Come on. 1 for swelling of the entire freaking leg. 1 for swelling of the calf has to be greater than 3 centimeter. Where do I measure it? You get the tibial tuberosity, go down 10 centimeter and measure this circumference. If this circumference is greater than 3 centimeter of swelling, you give the patient 1. Collateral non-varicose superficial vein, because when one of the veins are blocked, anastomoses are going to open. These anastomoses are called collaterals. If you see pitting ankle edema, you give 1. But if another diagnosis is more likely or at least as likely as DVT, you subtract 2, because if it's not if it's possible it's not DVT, it's less likely that it's DVT. It's called common sense or circular evidence, depending on how you look at it. I cannot memorize all of these criteria. Okay, calm down. Just read this, and everything here is here except for swelling of the entire leg. 46-year-old female, oral contraceptive, medical history of cancer. So we give 1. Ovarian cancer, she's treating currently, so it's current cancer, okay? She has had major surgery, you give her another 1. Fine. Long flight, so recent immobilization. Now she has a score of 3 so far. Next, right calf swelling greater than 3 centimeter, and you add another 1, so now she is having 4. There is tenderness, so tenderness is here, you add another 1, now she's 5. Pitting ankle edema and collateral non-varicose superficial veins, so now she's 7. So her Wells score is 7 for DVT. Let me ask you this. Is she high risk, low risk, or moderate risk? Very high risk. High probability. This lady has DVT. Shut up. It's over. Don't argue with it. Just freaking treat it. So here is my version of the Wells criteria in a crazy mnemonic. We have 8 points. Each point will give you a score of 1. Alright, let's do them. First, cancer. So here is 1. The second thing is tenderness. So here is 2. 3, entire leg swelling. This yellow leg. So this is 3. 4, immobilization. 5, bedridden or major surgery. 6 is the pitting edema. 7 is the collateral veins. And 8 is just swelling of the calf. So this part is swelling of the entire leg. This is just swelling of the calf. It cannot get easier than that. Just get your head out of your sphincter. Because repetition is the mother of pedagogy, let's do it again. 1, cancer. 2, recent immobilization. 3, bedridden or major surgery. 5, swelling of the entire leg. 6, swelling of the calf has to be greater than 3 centimeters. 7, collateral non-varicose veins. 8, pitting ankle edema. Boom! Each one of them, you give a patient 1 point. If another diagnosis is as likely as DVT, you subtract 2. Instead of saying, oh, CSD and those crazy mnemonics that you guys do, this illustration will stick in your mind. There is a difference between DVT and ruptured popliteal cyst or Baker's cyst. Clinically, unilateral calf pain, redness, hotness, tenderness, pitting ankle edema, non-varicose venous collaterals, etc., etc. Ruptured popliteal cyst, unilateral stiffness, tightness, swelling at the back of the knee, pain at the back of the knee radiating to the calf. Pain increases when bending over or fully straightening the knee. The history, Virchow triad, so stasis, endothelial damage, hypercoagulability, the long flight, you know this stuff. Meniscal tear, arthritis, especially rheumatoid arthritis. How about Homan sign? Positive in DVT, negative in ruptured Baker's cyst. D-dimer elevated, normal. How to confirm the diagnosis? Ultrasound for both of them. By the way, be careful. This Baker's cyst can actually lead to DVT. Ooh. Here are 3 questions for you. Please pause and try to answer. Okay. Does D-dimer assay detect fibrinogen degradation products? And the answer is no. It detects fibrin degradation products. Please be specific. The stabilized fibrin. 2. Would a patient who has broken down a platelet thrombus in his or her coronary artery have increased D-dimer? And the answer is yes. But this is just a plate. Calm down. If I say thrombus, it implies there is platelet and there are coagulation factor. That's why I call it thrombus. If I just want to say platelet, I'll say platelet plug, not platelet thrombus. 3. Would a patient who has DIC show increased D-dimer? Absolutely yes. In DIC, you're forming clots, then breaking them down. Forming clots and breaking them down. And forming clots and breaking them down. It's weird. D-dimer is actually helpful when the patient has low probability. Translation. Let's say that you have patient A. Patient A has low probability of DVT. What do you mean? I mean she's 21-year-old female. And she's having painful calf. When you diagnose the calf, everything is okay, except it's slightly tender. That's it. Other than that, everything is perfect. In this case, doing the D-dimer is actually very helpful. If it comes back negative, this lady does not have DVT. I have successfully excluded the diagnosis because she had a low probability to start with before performing the D-dimer. Okay, fine. Contrast that with a lady, B, who is high risk. What do you mean? I mean high pre-test probability. What do you mean? I mean she has current cancer, major surgery 5 days ago, long flight, right calf swelling, tenderness, pitting ankle edema, collateral non-varicose superficial veins. This is a patient with extremely high pre-test probability. Translation, let's do the D-dimer. If the D-dimer came back negative, I don't care about the D-dimer. This lady has DVT, and I don't care about a stupid lab test. This is what I mean by saying D-dimer rules out DVT in selective population when the pretest probability is low. But when the pretest probability is high, it's a freaking clinical diagnosis. Don't care about the D-dimer. But I don't believe you. Okay, do an ultrasound and you will see the clot. Shut up. Clinical uses of D-dimer, 95% sensitive, not that specific. It rules out DVT or PE when the pretest probability is low. The most sensitive test to diagnose DIC. It stratifies the risk of recurrent VTE, venous thromboembolism, especially in women. This is called risk stratification. I've told you if it's less than 250, risk of recurrence of DVT is low. But if it's higher than 250, the risk of DVT recurrence is high. After giving a patient TPA for coronary artery thrombosis, follow up with D-dimer assay. If the D-dimer started going up, whoops, there is a clot. Here are 5 difficult questions about D-dimer, and the answers are going to be available at patreon.com/medicosis. My favorite part of the lecture, clinical pearls. Virchow's triad increases your risk of venous or arterial thrombosis. Polycythemia vera, which is a myeloproliferative neoplasm, as well as paroxysmal nocturnal hemoglobinuria, which is a freaking hemolytic anemia, increase your risk of DVT and PE. Pulmonary embolism is the most common preventable cause of death in hospitalized patients because most doctors are idiots. That's why I'm always yelling at you, because I want you to save patients' life. The most common site of thrombosis in case of DVT is deep veins of the lower leg. So if this is your leg, the deep veins here, this is the most common site of what? Of thrombosis. But the most common site of embolization is the femoral vein. What do you mean by embolization? I mean when this clot starts to dislodge, because as you go up, the veins are getting larger and larger and larger until, boom, this clot can dislodge and go up until you die of pulmonary embolism. Most cases of pulmonary embolism came from a DVT above the knee because the veins are getting larger, they dislodge at that level. Most calf vein thromboses do not embolize. This is an example of DVT without a PE. How do you know that this patient has DVT but not PE? We will order a CT pulmonary angiogram of the lungs and you will see no clot whatsoever in the lung. This is just DVT. How do you treat it or manage it? Okay, I know it's controversial, but if it's painful, you give heparin. If it's painless, you do not give heparin. You just repeat the ultrasound again and again and again to follow up. Thank you for watching. Subscribe, hit the bell, and smash like. Follow me on Facebook. I have 100 cases there. You can get my Dropbox notes, including the slides of this video, some premium videos, some cases, some post notes, PDF notes, audio notes, available at patreon.com/medicosis. Thank you so much for watching. This is Medicosis Perfectionalis, where medicine makes perfect sense.